Namaste. Listen, we are going to talk about very grave things, but that doesn't mean that we cannot start without a smile. Please give me a smile. Okay, listen. There are six of us in the room, so I'm wearing the mask, but just so that my face is introduced to you. Hello. As Sridevi said, it's so good that you are involved in this course because I personally feel the importance of physiotherapist in patient care is priceless. And in this field, which we are concerned with so very much, with the well-being of a person, comfort and quality of life, it's particularly important that physiotherapists should be at the heart of it. So, the facilitator is Mr. James, who is here, who is in charge of physiotherapy in our unit, and he'll also be presenting to you a bit later. But my job is to give you the introduction. I wish we had enough time to get to know everyone. They are from different parts of the country.
Yes,
Right?
sir. Outside country also. Yeah.
Okay. So, for those who are coming from outside India, a warm welcome to this Indian course. For everybody who is joining, warm welcome to the course. I'm going to share my screen. Hello, India. Okay. Deal with during the day. For one thing, what is palliative care? I will not go to detailed definitions. We can do that later. But I will concentrate on this one sentence. Palliative care is management of serious health-related suffering. Palliative care is management of serious health-related suffering. If there is suffering, we come in. That may have to go along with treatment of a disease. It is very often people mistakenly believe that palliative care is only for end of life. It is not so. Palliative care is for all serious illness. The second point you can see there, that suffering can be physical, which is what we most of the time get concerned with. That's for us. But for the person, the social, mental, or spiritual issues may be the most painful, and that we will have to take into consideration. You and I are healthcare providers. We have to be concerned with health. We'll come to that. Third, palliative care is everyone's business, not only the physiotherapist and the MBBS doctor plus BDS doctor plus nurse, etc., but also the common man. Fourth, we will have to reach people where they are when they need care. We sitting in some institutions means that the most needy people will not get to us. We will have to get to them. And five, whether it's a volunteer, community member, physiotherapist, or a doctor, I, as the healthcare provider, have to be accountable. Some core values will have to be kept. So these are the important points that we will talk about. But to begin with, why I said you, every one of you. The first name is Abhilash. Abhilash, Fatima, Ajita, all of us, we are all healthcare providers. And as healthcare providers, we have to understand that health is not only absence of disease or infirmity. Health is physical, social, and mental well-being. If in the course of our treatment, we are looking after a joint or an illness so well, but the patient is feeling worse, patient is getting depressed, then we are not improving the condition. So we will have to think of this in the overall well-being of the patient in consideration. And as defined by the Bioethics Unit of Indian Council of Medical Research, your duty and mine, all healthcare providers' duty, primarily is to mitigate suffering. Mitigation would be prevention and treatment of suffering. Our duty is to cure when possible, relieve suffering, relieve any element of suffering as often as we can, and always to comfort the patient. And the ICMR adds, there exists no exception to this rule. This is non-negotiable. You and I have the responsibility to relieve suffering. And especially at the end of life, we are doing very badly. You also may be involved in care of the people who are dying. Medical system as a whole, any part of it, is often concentrated so much on diseases that we forget quality of life. And as far as the end of life is concerned, Sanghamitra said, the poor die in misery and neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators, no one gets a pain-free and dignified death. You, as physiotherapists, are very often involved with seriously ill patients, and eventually they will deteriorate. That's the time when we have to still look after the overall well-being of the patient, not only of a joint or a group of muscles or an image that we see on the screen, but on the whole person. And we have to do this without destroying families. Unfortunately, India is among the worst 12 countries where destruction of human beings happens because of healthcare. More than 4% of our population every year goes below poverty line because of healthcare expenditure. And I earlier just mentioned this. The Astana Declaration is a global declaration of all countries, including India. Astana was the capital of Kazakhstan. That's where the meeting took place, and together the World Health Organization arrived at this Astana Declaration. And two sentences I am quoting here. Healthcare should reach people where they are, when they need it. Healthcare should reach people where they are, when they need it. I know. Physiotherapists, more than anyone else, very often get to patients' homes and treat them. That's the way it should be. Only thing is, that should happen not only in the cities, but everywhere. Secondly, healthcare for all has to be healthcare with all. That means, you know this, even if you do the best care for the patient, unless the family is supportive, the care will never be complete. And it's not only the family, especially when you go to rural areas, it is the neighborhood all who gets involved in it. And we have to engage with the community in the care for the patient. So, as physiotherapists or as a medical doctor, we all healthcare providers, when we look at suffering, we look for each individual elements of suffering, physical, social, mental. And in that context, as far as physical suffering is concerned, do you sometimes worsen physical suffering? With a good intention of improving functionality, do you cause pain during the procedures? We also do. Sometimes the procedures that we do are painful, but we need to achieve a balance. When we are treating an elderly person who is bedbound, we have to make sure that as much as possible, pain has to be relieved during the processes. And eventually, if the person is not feeling better, we are failing. Even if you have improved a joint function or an overall muscular function, the person has to feel better. You will notice that the 4 circles that you see on the screen are all encroaching onto each other. Physical suffering will cause other kinds of suffering. Sometimes patients hate doctors. Patients sometimes hate physiotherapists also, right? They see you as people who will cause more pain. Even if 1 hour of pain causes better improvement, maybe it is worthwhile. But as far as possible, that you know that if we do that, we may also cause the person to go into depression. When I treat somebody and the medicine causes serious side effects, it is not only the physical suffering of side effects, it is also the patient's unhappiness, may go into depression. All those can be problems. So remember, each of these encroach onto the other. There are 30 people in attendance. Some of you must have gone through somebody with a serious illness in your own family. Many of you. How many? Please raise your hands. Those who have gone through the experience of somebody in a family going through serious illness in your own family. One. The screen in front of me, I can see 4 hands raised. And there must be many more that are not visible right at the moment. Usually, if I ask this question in an audience, approximately 1/3 of people raise their hands. Those of you who went through this experience will know about these circles, how the suffering is in various domains. Now, if I sit here and talk, I have not gone through a personal experience of serious health-related suffering in myself. I've not even had such an experience in a close relative, except in somebody from previous 2 generations towards the end of their lives. They all had reasonably peaceful exits. So I thought maybe I shouldn't talk too much about it. I should ask somebody else to talk about it. Ashla, could you come in and explain to the audience what your own personal experience was? Ashla is one of the trustees of Palliative India. She fell off a train 10 years back. Correct me if I'm wrong about the years, Ashla. Injured her cervical spine and became a quadriplegic. I would like Ashla to share her experience with the injury, with the period of treatment in the hospital, and thereafter your life. Can you do that, Ashla? Thank you very much.
Sure, sir. So, good afternoon, everyone. So happy to be here sharing my story, and thank you all for joining this course. I'm sure that you'll be able to relieve so much of suffering when you go back, when you finish the course and go back. So thank you. So as sir was saying, I met with an accident 11 years back, like fell off a running train. So one moment I remember I was flying out of a train which was moving so fast, and the next moment I remember was being in a hospital bed, not able to move anything. I had a very big collar on my neck, and I couldn't move my legs, like I couldn't move my body at all, to say that. So I was there lying, not knowing what was happening. And then I was told after some time that, okay, I will have to go through a surgery in the next 3-4 days. So actually, I broke my spine, C5, C6 vertebrae, and they had to fix it. So they did the surgery. So maybe I think it was 5th day of my accident. So I went through the surgery and they fixed it. I was back to ICU again. So I was there and I never understood what was happening to me. And I was from school days, I stopped my biology from my school days. And even then, I didn't like that subject much. So I did not know anything about what is the result of spinal cord injury or what is it doing to your body, how is it helping and all. So I got this opportunity to learn it by experience. So only when you lose it, you know that, okay, what it was doing for you. So at that moment, I did not understand what was. So I was just being there bedridden and people talked, like I know that I went through a surgery and all the attention from the doctors were to my spinal cord injury. So they fixed it. They were so worried about the infections which I may get. So I was in ICU for 2 weeks, getting all the care. And it was, I still remember, it was only one person who actually asked me, okay, what do you want? Or I was rather so like I couldn't lie there at all for even for a moment more. So I asked, I can't do this. I want something to read. So one of the nurses, Ashwati, she came. She actually found some table to fix my bed, and found an old magazine for me to read. So I couldn't read that much, but then at least she tried that much. She uh, gave that effort of finding some table to me and finding an old magazine, and then taking the trouble of lifting my bed up and then making me sit and try to read. So that is one experience I remember from my ICU. And then I was in hospital for almost 1.5 months, because I come from a very rural village of Kannur, and I couldn't think, my family couldn't take me back home and come get me back for my post-operative review after 1.5 months, which they insisted on. So we decided to stay in hospital. So I was there in the hospital getting some physiotherapy, and I was discharged. I still remember I was discharged without, I didn't know, and like I don't know about my family or my other members, but I did not know about the bowel care or bladder care or what I had to do after getting discharged from there. So I went back to another hospital for getting physiotherapy, and then there I got an infection. So I was admitted in another hospital for my respiratory infection. So there I got all the attention to my respiratory infection and also for my spinal cord injury. So I still remember those days wherein people come and ask about, okay, what is how is my pneumonia, and taking care of it. So and then it was a journey of 4 years of hospitalization. I never went back home. Even for today, that was the last journey I took from my home, and I did not go back home. So events happened in life, and I was from one hospital to another hospital, and I ended up in in a private hospital for 4 years after that for physiotherapy. So I'm so grateful for all the physiotherapists who actually helped me, getting me to this level for sure. So at that time, they used to care for me, and then it was through my physiotherapy that I learned to get up, sit, and then maybe got the confidence to sit up in a wheelchair for a long time. And then I learned to use my laptop again, and I learned to write again. So it was all encouragement from physiotherapists, which helped me go through this process. And to say, what sir had told or shown you as elements of suffering from physical, social, mental, and spiritual. Yeah, I was going through all of those. Maybe some of my physical conditions, at least my spinal cord injury got the attention all through. But my emotional issues, like I didn't know what was happening. Like it was people were talking about me. Maybe doctors were talking about me, but not to me. So I did not know what was exactly going to happen, and I did not have any idea at all about my prognosis or how to handle my life after. So at least during the initial days. So that was happening there, and then my mom was spending so much from her pocket for my physiotherapy and hospital stay. And end of 4 months, we ended up without any money at all with her. So at least she saved a lot of money for my marriage that anybody does for girls in the family. Even if they don't educate you, they will keep money for your marriage. So that happened even to me. So she had actually saved some money. So she spent every penny for my treatment. So we were broke by end of 4 years, and then I was questioning my existence. I couldn't call it life at all. I was lying down, getting physiotherapy, and I never could call it life. I only called it existence, and I was questioning that existence. Why do I exist? What do I do after this? So that was a lot of questioning from my end. Sir, do you want me to continue, or you will ask me questions later so that I can answer some specific questions when we go through it?
Ashla, I would like you to continue. Uh, I think you were giving very powerful lessons, especially you saying that you were existing but not really living. Maybe that's something that will help everybody to think. But maybe a little more like your progress thereafter,
Okay.
maybe about your mother.
Thanks.
All those things
Sure.
might be of interest to all of us.
Okay. Okay. So um, it was actually I got that physical improvement from the physiotherapy center, and I was also helped by some people emotionally at that time, because I made friends with people, and it was I'm not sure whether it was as a capacity of a physiotherapist, but maybe as friends. And it was those times wherein I got to like talk to people, and then like those times those physiotherapists gave me some realistic goals. Okay, let's do this, let's try this, you write this, or we sit for some time for during the day, and then maybe we'll increase gradually, and those kind of things. And then they talked about, okay, what did you study, what did you do? And then when I explained that, okay, I did my master's in computer application and I was working as a software engineer, when I fell down, some of them, and at one person in particular, he asked me, okay, you were working there, and why don't you try to do some online jobs, and you're able to use your laptop again. So I was actually training myself on my laptop also, and when I got some confidence, actually I went back to my work. So that was the help or encouragement given by the physiotherapist, not as in capacity of a physiotherapist, but as a friend, encouraging me, taking me, or challenging me sometimes, saying that, okay, you like, otherwise I'll not feel like doing it, or I think that, okay, it is not I'll not be able to do it, and then, okay, take up a small bit of time and then you'll be able to do. So that encouragement and that challenges, that helped me uh, get through life. So after 4 years, at least I got some kind of a confidence that, okay, I'll be able to do something. And it was at that time that I was thinking about, okay, what should I do with my life? Not existing but doing something. So I searched, and even my physiotherapist friend helped me to search for some places wherein I can go. So my idea was to find a place wherein there are people to care for, so that I get the care I need. You all know, as a person with quadriplegia, I needed a lot of care for my daily activities. So wherever I get that help, and in turn, where I am able to do some bit with my left out ability, like using my laptop or talking and reading, things like that. What can I do? Maybe I can go to an old age care home wherein I get the care I need, but I'll read to all people who would want to read but can't read at that point of time because of their age related issues. Or maybe I'll go to some children's home wherein I get the help I need, and I can also teach them math or English, or help the office with some kind of an administration. I didn't have an idea about what, but I wanted to be of some use. I didn't want to exist at all. So, okay, that is when I found Pallium India. It was long story, and one of my like one person I knew, or I saw through a social media. So she came forward and she actually searched in many places, not just one person. There were three people. So they all got together searching for a place for me, thinking that, okay, maybe we will find some place for this person. So they searched. It was a long search, and then finally one of them found Pallium India for me. So I called Pallium India's IP number, and then I emailed Dr. Rajagopal, and I was here. And after 2 months of that call, and I call it a blessing, because for me everything happened after that was like a blessing. So I reached here, and that's when things started getting some clarity. So I reached Pallium India, and I was actually pushing my wheelchair through the corridor, and people, Ashla, when did you come? So see, all these 4 years, I have actually forgotten my name also. Only very less number of people used it. My mom, of course, when we were in hospital, and then some people who know. And for random people who come and go, I was just a patient in room number 3, patient with quadriplegia, and that patient, that was it. So being called and treated as a person was so different. And then next day, Dr. Rajagopal came, and he was asking my mom, what is her name and how old is she? What are her health issues? And how is it to care for a daughter like me? Because I am 32 or 31-year old. I was 31-year old at that time. And then all my needs were like a 6 months babies. So how was it, what was it doing to her? So in that moment, I realized that in last 4 years, she was never asked for her name, except when she had dengue fever and she had vertigo once or twice, and they had to write a prescription. So for that, she was asked for her name and age to write in a prescription. But other than that, as a person, she was never even once, I remember, person asking her about, okay, how is she doing? So if this could happen in a healthcare setting, why was it given to me for the whole 4 years of my life when I was suffering? And it was not just me, it was my mother also suffering along with me, because we both did not know how to handle the situation at hand. I was depressed about my situation, and she was more depressed about mine. And then caring for me was not easy. She had her backache, and she had her fatigue and issues, and then lifting me and giving me all the care I need. End of the day, she'll be angry, and I did not know how to handle it. So all those happened to me all these 4 years, and it was never heard about how we can treat a person instead of a disease or instead of a condition, not just doing physiotherapy and not just doing the surgery and fixing things. How can I be treated as a person? How can my mother be treated as a person? And we as a group could be helped to go forward with our life. So that was a revelation which I got, or I found when I reached here in Pallium India and found palliative care. Sir.
Ashla, thank you very much. You all heard Ashla, her lived experience. I want you to sit quietly and think about what she said. Then I request you to write on the chat box what is the thought that comes uppermost in your mind. One thought. Sripriya,
Sir.
shall we give them a minute
Sure, sir.
to reflect on everything? Think about what they want to contribute and contribute.
The early birds can definitely start putting their thoughts in the chat box.
Written is one message. I think it's time you all chipped in with some thoughts. Everybody, please, doesn't matter if anything is repetition, not only for cancer patients. Does somebody have a writing pad? Not only for cancer patients, but also for all, even for those in need. Not only medical aspects, see as a whole person, biopsychosocial model. Okay. Utmost respect for any human being. Murugavel says, Murugavel, respect to that thought. Ultimate respect. Okay, we'll come back to the whole things a little later. It's like a tidal wave now. So Abhilad says, I'll go from here to back. Abhilad says, consider that person as a human like being like this, not just a patient. Palliative care focus on all aspects, not only medical. Suffering is inevitable, but its intensity can be reduced significantly with holistic palliative care approach. Monica says interdisciplinary approach followed for improving quality of life. Yes, we all working together. Maintaining hope. There is no life without hope. But that hope has to be realistic. It's just saying everything is going to be okay. You will walk in 2 months. That may not be wise. At the same time, saying you will never walk again destroys hope completely. You have to break the reality down to pieces. Give a little bit at a time. Okay, Vaishnav, shall we start the chat box from the top and see whatever people have written? Empathy is thinking about the problem from the person's perspective, thinking from the patient's perspective and the family's perspective. Ashla, can I ask you a question? What did you get? Sympathy or empathy or both?
It was most of the time it was sympathy, sir. And I don't think people did understand about empathy at that time. When people ask me questions like, okay, you can't walk at all. Okay, for how long did you try this? Did you try that? All those questions showed me that it was only sympathy.
And
Very rarely empathy from rare people.
And what did sympathy make you feel?
If sympathy, I did not want sympathy at all, and it actually destroys. I remember, like, when people show me a lot of sympathy, I find it difficult to get sleep at night. So why do I live? I don't have to live this way. So that is what sympathy did to me personally.
So,
How do you like sympathy?
so sympathy is just like, they are not thinking about, they are not thinking in our shoes when they are sympathetic towards us. They are not feeling what we feel. As a person, I have felt that. When somebody is sympathetic toward me, they are just saying their emotions. They are not feeling what I feel. So they
And
can't
they are
relate.
secretly happy that it is not them, it is me. That's what I felt.
Oh, yes. Caring and kindness are essential for healthcare providers to reduce difficulties. Thank you, Kumaravel. Hey, HPCHRC, an institution that I know very well. You are from Asia, Dr. Priyanshu?
Yes, sir. I'm working with Dr. Vidya here.
What do you do?
Sir, I'm a physiotherapist.
Huh? Physiotherapist.
Yes,
And
sir.
you are a PhD doctor or a medical doctor?
Sorry, sir.
They said doctor there, Priyanshu. What kind of a doctor are you?
Sir, I'm a physiotherapist.
Okay. Priyanshu says palliative care is not only for onco patients but even for those in need. It is not only for cancer. Of course, there shouldn't be a caste system. Whatever be the disease, it is the suffering that matters. Thank you, Priyanshu, for that comment, and say hello to Vidya for me. Murugavel says we should not treat any patients focused on medical aspects. Rather than, well, let us say Murugavel patients focus only on medical aspects. Certainly, medical aspects also have to be considered, but rather as a whole person, biopsychosocial aspects, with utmost respect to human being. And I already conveyed my respect to you for thinking about respect. Every human being deserves the respect of others. I see so many people whom I have not met before. Smisha, Kanchana, Sunil Kumar. Oh, that's our Sunil. That I have seen. Anubama. I don't know you, but I know that you will have something in you that is superior to me. I treat you with respect. So thank you, Kumaravel, for bringing that. No, Murugavel for bringing that. Wait. Vandana says, Ashla has suffered both physical and psychological issues. In this phase, the doctors or the caregivers have to deal with both the issues, or the caregivers. Yes, that's what did not happen. Did you notice, friends? During her conversation, she expressed appreciation for the physiotherapist. Ashla, I don't know whether you recollected it yourself, the only group of people that when you were talking, you talked with some warmth. They're either in palliative care or the physiotherapist. You said the physiotherapist, you did not talk about how they helped with your joints or muscles. You were saying that how they were motivating you. You were saying they were asking about your software engineering background. They encouraged you. Please note, after all your hard work, what people remember is those elements of empathy. Sri, am I audible?
Yes, sir. Perfectly audible.
So, Ashla was saying that what she remembers, I was saying that what Ashla seems to remember with kindness, with happiness, are the non-technical aspects of the care by physiotherapists. Uh, Let me look at the chat box. Just give me a second. Sorry for that interruption. I'll have to move faster, of course.
So you want me to read out in case?
No, I can.
Okay.
Thanks. Uh, Maintaining hope, interdisciplinary approach. Have to consider, Abhilad says, have to consider the person as a human being like us. Uh, Manu Shijin, palliative care focus on all aspects, not only medical care. But the point that we are making is that as healthcare providers, whether you are a physiotherapist or a social worker or a doctor or a nurse, we all have to focus on all the aspects. We have to listen to understand. Thank you. Very perspective, Smisha. We did not talk a lot, but Ashla mentioned how the empathetic communication helped her. Multidisciplinary team approach was needed. Yes, but every member of the multidisciplinary or interdisciplinary team may not be empathetic. I totally agree, Bristi, that multidisciplinary team approach is important. And I am also adding that every single member is important. Okay, the other answers are mostly repetitions. Hey, did you notice, Sri, that between them, they have explained what palliative care is already. I don't have much more to say. I'll come back to my presentation. Ashla, I am putting upon the screen the WHO definition of palliative care. In the beginning, ladies and gentlemen, I said palliative care is treatment aimed at improving quality of life. That I mentioned already. Now, this is the long definition. Ashla, in her description, mentioned how her quality of life was improved by the physiotherapist. How palliative care gave attention to her family also. Ashla, but here we have a problem. By the WHO definition, palliative care is for life-threatening illness. Did you have a life-threatening illness, Ashla?
Yes, sir, I think so.
Sorry?
Yes, because my life was threatened by that death. I was there in that single bed for all these 4 years, and the only place I went from there was to my physiotherapy room, and I could never call it a life. So in that sense, my life was threatened by my spinal cord injury.
So prevention and relief of suffering, pain and other problems, physical, psychological, social, and spiritual. Ashla, during these years, how many? 6, 7 years of your living in Pali in India, you have seen quite a lot of people die. You have known some aspects of bereavement care. Would you like to tell them something about bereavement care, the relevance, and an example perhaps?
Yes, my most of my experience with bereavement care is with children after losing their parents. So it is a vacuum when you lose somebody. As a person, I have experienced that. And there is, yeah, of course, there is a community or there is an extended family to come up and help. But many times it is limited for some duration or limited in what they can do, maybe with rituals, and that's it. And emotionally, what you go through, you will have to go through on your own. And even especially children, they are never told what is happening, and they worry about, okay, my dad is gone and whether my mother is going to go now or what is going to happen. And one like single parent is always busy with finding the family or running the family on all her by herself, and then they don't have time for caring for people. They themselves are going through a lot of emotional issues. So that is the time when we really need to help and handhold that family to go through that situation. So
Thank you, Ashla. So the concept of palliative care evolved from a definition of WHO many years back, 32 years back, of being applicable when the disease was no longer responsive to curative treatment. From there, it moved on to life-threatening illness, the definition that you saw just now. And today we talk about, or WHO definition is officially still this, but we talk about what the Lancet Commission says, prevention and treatment of serious health-related suffering. I have just stolen this from an article explaining the aims of physiotherapy in palliative care. This was what they said: maintain optimum circulatory function, prevent muscle atrophy, prevent muscle shortening, prevent joint contractures, influence pain control. Influence, okay. Optimize independence and function, increase confidence, educate carers. I gave some thought to it. I thought I wanted to add a little more. I also wanted to rearrange the priorities. So after I took that liberty, I added one line in the bottom and one line in the top. You and I, all of us, should aim at improving quality of life. Maintaining, concentrating to, this is all important. Circulation is important. Muscle is important. Joints are important. But maybe quality of life is even more important. We should optimize independence. But all the others I have retained. I have not taken anything away. But I have put in optimizing independence first. Someday, I know, I will also have an illness. I'll be bedbound. I hope whoever cares for me allows me to be as independent as possible. That is one hope I have. So I have put that in the top, kept all the others there, and I will particularly request you. Pain is damaging, it is destroying, it destroys confidence, it makes person wish I were dead. And that's important. The other article said educate carers. Education is not enough. Empower them, train them, help them to do the minimal things that can keep the body active and intact. And essentially, I believe our function should be to rehabilitate a patient to a person. A patient is somebody with a disease. A person is Ashla. A patient was Ashla, that case of quadriplegia in room 3. Ashla is a human being, a software person, somebody who is contributing to society. I think, I hope eventually every one of us will concentrate on this task of transforming a patient to a person with a personality, with hopes. For this, community engagement is important. There are 30 people here. You will continue to be physiotherapists. May not be in palliative care units. Maybe it may not be. Wherever you are, you following this approach, concentrating on quality of life, empathy, hope, dignity, and then that will be the biggest achievement as far as I am concerned as a tomorrow's patient. and only a few people will be working like Priyanshu, working in palliative care units, or James in our team and his colleagues working in our team. Maybe if some will work only in palliative care, the majority will be applying these principles in your own work, whether you are in a cardiac unit or a pulmonary rehabilitation unit. And for this, the disconnect between the poor people in the villages and the huge hospitals where you work have to be reconnected. And for that, we will need the community around us, the neighbors, the people who are working in the, say, maybe the panchayat people, social organizations in the field. And James and his colleagues actually reach out to people in their homes and do the work there, so that this man, he will never possibly see a hospital again, but he has the care delivered to his home. And whenever we give care, we try to remember children, these families, they are often left without any information. Just giving some information to them, giving support is an important part of our work. Integrating palliative care into all healthcare is what was advised by World Health Assembly. That means you also incorporate the principles of palliative care into your work. The key messages to repeat, this is what I started with. Healthcare providers have to treat suffering. Suffering can be physical, mental, social, and spiritual, including financial. Palliative care is not only a few people's business, not only professionals' business, it is also the community, the neighbors, the family, everybody. We have to reach people where they are, when they need care, and all of us have to be accountable and follow ground rules or core values like empathy, dignity, etc. I'll stop there and take any questions.
Are there any questions from the participants? Kindly unmute and ask your questions. Or if you can't unmute, please type it in the chat.
Questions or comments, Sri?
Not yet, sir. There are no comments in the chat. If anyone wish to speak, please unmute. So there is a question, what is SHS?
Good lesson. We should not use. I did show the full form and I showed it first. So, but I'll come back to this. Maybe every time I should. Serious health-related suffering. Serious health-related suffering.
Any other questions? Anyone wants to unmute? So there are no questions in the chat so
Okay,
far.
it is time we can go on to James's session. Sridevi,
Yes, sir.
there is a patient who needs attention, so may I leave?
Yes, sir.
Okay, thank you everybody. It was nice meeting up with all of you.
Thank you so much, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Now we have a case presentation. As mentioned in the beginning, today we will be doing a case presentation from our side so that you will get an idea how a typical session looks like. And this template is shared already in your iEco platform. So whenever you log in, you can see a case presentation template being uploaded in that. So you can use that template and look at the coming sessions, and according to the session topic, please choose one patient that you have seen which can be discussed. So this is not for finding fault or giving answers. This is just for discussion so that we all can learn from each other. We get comments from you. We'll understand in what setting you are working, what all can be done in your setting, what all things we can take up from your practice. So this is a mutual learning platform. This is not for finding any faults or making corrections to the presentation. So kindly go through the template, and next week onwards, it should be from you that will be presenting this case presentation. If you have any specific topics in your mind, you can choose accordingly. If someone is interested in pain, you can choose a patient with pain, which you find difficult to manage. So according to the session, you can choose whichever topic that you want to present. I hope I'm clear. We'll again brief it if you have any doubts in the end. So today we have Mr. James. James is heading the section of physiotherapy in Pallium, India. So he's involved in the inpatient, outpatient care as well as in the home visits of the physical medicine rehabilitation team. So over to you, James, for the presentation.
Good afternoon, one and all. Thank you, Dr. Sridevi, for the warm welcome. And today we are going to see a case. And the patient details is the name of the patient is Mr. X, and he is 21 years old, male. And the date of admission is 24th November 2021. And his diagnosis is spinal cord injury, that is hemorrhagic contusion of spinal cord from C3 to C6 with fracture of C4 and C5 vertebrae, that is, he is quadriplegic. And his present complaints are he has pressure sore, and he also have body pain, and we are not able to score. And he also has a cough and breathlessness occasionally, and he is not able to do his activities of daily livings. And while looking into the history of illness, on 9th of September 2018, he was jumping into the pond, and he got his head hit against the floor, and he developed weakness of upper and lower limb, and he was taken to Medical College Hospital Trivandrum immediately, and they have done CT spine and MRI, and they are diagnosed as hemorrhagic condition of the spinal cord from C3 to C6, and they have taken him to neurosurgery consultation, and he underwent a surgery of C4 and C5 anterior cervical cordectomy with fusion with expandable cage, and they have also done the temporary tracheostomy. And while moving to the examination part, his vital signs are within normal limit, and his range of motion is not able to assess because of pain, and his muscle power on MMD, manual muscle training testing, his wrist extension and flexion, he has a grade 2, and his shoulder abduction and adduction, he has a grade 2 of power, that is eliminating the gravity, and his elbow flexion and extension also, he has a grade 2, and his attitude of limb is bilateral lower limb are externally rotated, and his FIM score, that is functional independent measurement score, is at the time of admission was the total score was 42, And by the time of discharge, the total score we have gained total score was 47. And as I have mentioned, he is having pressure sore on the right side near ischial tuberosity, that is a fourth stage wound, and like the left side also he has a fourth stage wound, and on his sacral area he has a second stage wound, and he's on continuous bladder drainage, and his bowel opens with a stimulant laxative, stool softener, and suppository on alternate days. In the treatment and significant investigation, on his first admission on 16th of June 2021, our goal was to do the bedsore management, physiotherapy intervention, and psychosocial support. And after that, he got discharged on 18th of that month. And the second admission was on the 25th of the same month and the same year. And at that time, he had pressure sore on sacral area, second stage, and he was on depression. He had some psychosocial issues, suicidal thoughts, and for the management of physiotherapy. And we have done psychiatric consultation for this patient. And during our IP admission time, we have healed his pressure sore, and we have given proper caregiver education, and he got discharged on 10 of 8 2021. While moving to his psychosocial aspect, he is from a poor socioeconomic background family, and they have a debt of 2 lakhs, and his father is the breadwinner of the family, but he is alcoholic and he's not well supportive. He has a brother, and his brother is with drug addiction, and he's also not supportive. And his mother is the only one who earns money, and she's a daily wager. And he belongs to a Christian religion, and his main psychosocial, his main concern, he always says that he's worried about his mother, and he always wants to support his mother. And these are the medications of this patient: tab paracetamol 500 mg 6 hourly, and tab baclofen 10 mg, tab gabapentin, then tab bisacodyl syrup cramafin. And we have done ENT consultation, and as his tracheostomy site is not fully closed, and they are planning for suturing, and his wound is also wound cleaning is also doing regularly, metronidazole irrigation, then debridase ointment, and with megahil ointment. These are his physiotherapy interventions. We regularly do passive range of motion exercise for his bilateral upper limb and lower limb, and active assisted range of motion for bilateral shoulder and elbow. As I have mentioned, his MMD is grade 2 for shoulder, elbow, and wrist. We used to give active assisted range of motion for bilateral shoulder and elbow. And we also do stretching exercise to prevent contracture. And splints are given for upper limb and lower limb, like cock-up splint and angle foot orthosis. And we regularly do positioning to prevent bed sore every 1.5 to 2 hours regularly. And as you can see on this screen, his main concerns, this is the total pain. His main physical problems are pain, pressure sore, and difficulty in doing ADLs. And the psychological concerns are depression, suicidal thoughts, and being a burden. Then his socioeconomic concerns are like he's from poor socioeconomic background, and their depth of around 2 lakhs, and he's worried about his father and brother who are not supportive. And his spiritual concern is why this happened to me. And we can summarize that as he's a 19-year-old male patient with traumatic paraplegia with a lot of physical, psychosocial, psychological, social, and spiritual issues. These are the case. We have seen a case related to quadriplegic, and while coming to the discussion points, what can be done for providing total care for this patient, or how to improve the quality of life of this patient as a palliative care team, or what are the other physical and vocational rehabilitation that can be done for this patient.
Thank you, James, for the presentation. So we would like to hear from you in a typical setting, what all can be done for this patient. Now you have heard his story. He's confined to bed with bed sores and other psychological, social, and spiritual issues. Just to make it clear that all these issues were explored, or we came to know about all these issues over a period of time. It is not during the first admission or the first day that we had the interaction, but over a period of time, we developed the rapport and then came to know. So the first visit, the problems were mainly physical, but once we started talking or exploring more into his life and his thought process, then we came to know that he was depressed, or he had all these thoughts and he had all these social and economic issues behind all this pain. So starting from there, what all can be done so that he can have a better quality of life as a palliative care team? What do you think should be done? Now we have heard Dr. Rajagopal talking about the total care concept. So we would like to hear from you. The suggestions, what do you think will be appropriate for this patient?
Ma'am, may I?
Yes, please.
Yes. Ma'am, since the patient is having both the physical and the psychological, social, every aspect of life he is suffering from. So we should send the patient, or we should try to have the other rehab professionals also to get incorporated with our team for providing the rehabilitation for this particular patient. And when all the 4 or the 5 professionals, when they work together, like the physical therapist, the occupational therapist, the counselors or the psychologists, the social workers, so when all the rehabilitation professionals will work together, they will definitely work for the betterment and to improve the quality of life of this patient, and the patient will definitely get the benefit from them. And also, for vocational rehabilitation, there are many centers, like the special vocational centers are running in India in India. So we can contact the officials there, and we can tell or discuss the discuss the problems or this person's history with them, so that they will going to have some kind of vocation which is according to the present functional status of the patient, so that there will not be any kind of financial burden also in the family as well as on the patient. And this will also motivate the patient that yes, he is definitely a part of the community, and he is not the useless creature in the community, but he is also a useful person. And this will again help in boosting the psychology of the patient, and definitely the physical outcome which we want to get better is also this will also going to get better, according to me. Thank you.
Thank you, Dr. Vandana, for that very, very valuable insights about this. Because as you mentioned, it is very important to make them, whatever pain relief you give, whatever therapies we give, it's very important that they should feel that they are, they exist and they are being useful for others. And they are, as Ashla was mentioning in the introductory session, they want to be with others in the community. They don't want to be always be surrounded by people on wheelchair, but they want to be with, I mean, like a normal person. They want to be called like a normal person, talk to them like a normal person, and to go out. Yeah, definitely there are restrictions these days to go out with more of a mingling with the society is not really possible these days, but still that's a very, very important part. And it sometimes take a lot of time for them to come into acceptance that they can even do that, to come into terms with people staring at when they are in a wheelchair or in a public place. So a multidisciplinary team, as you mentioned rightly, is very crucial in giving this total care when it comes to a palliative care team. Thank you so much, Dr. Vandana, for your insights about it. Anyone else would like to comment?
Yeah, hi, Dr. Gargi here.
Yes,
So
Dr. Gargi.
as we all saw in your chart about total pain, we discussed about physical, psychological pain. So going in that pathway. So for physical pain, we should take guidance of pain specialist so that if the pain is managed better way in a pharmacological or maybe non-pharmacological way, we can progress for our physical therapy sessions if the pain is well controlled. Then second, for bed sore, we do require nursing help because the nursing care that makes the bed sore suffering better, so that we can do. And difficulty in ADL, of course, we all are physiotherapists here, so we all know better what we can do to improve the ADLs by physical therapy. For a psychological aspect of pain, definitely psychologist or counselor will help that patient to cope up with the situation and to accept the situation and go ahead with that. So there we can take the help of psychologist. For spiritual also, I guess the counseling sessions could help. And for the social or socio-economic pain, we can definitely contact different NGOs who can support them financially or anyhow, if we can support the patient for his treatment or for his betterment, so that would help the patient. So here we can actually deal with the total pain of this patient. Thank you.
Thank you, Dr. Gargi. And is it very common in the setting, all of you, that question is towards all of you, this is a very common scenario in your day-to-day practice, I guess. So do you come across this kind of team approach in the place where you are practicing, where everyone is involved and all these are being discussed and then talk to patient? Is that how you practice in your place?
Yes, yes, yes.
That's wonderful.
So we do have meetings, the MDT meetings, and we discuss MDT rounds as well. So we discuss each and every patient and what best we can do as a therapist or as a social worker or as a nurse or as a doctor, as a pain specialist. So we put all the best efforts together to deliver the best care to patient.
Thank you so much. That's so wonderful to hear. The team approach is really crucial in managing this kind of serious health-related suffering, as Dr. Rajagopal was mentioning. And the suffering is usually in this type of patients, it's prolonged. That will be there for a longer period of time, so that it's really important to be aware of what they are going through. Then only we can reach where we want to reach. Thank you so much, Dr. Gargi. Anyone else would like to comment or suggest something regarding this?
May I?
Yes, please.
In my point of view, we try to arrange a group therapy for this type of patient, and they have got the 2 sessions in a day. So in the morning session, they do their exercise individually, but in the evening session we arrange a group therapy, and we do the breathing exercise and other exercise with all the members of a group. Like that, there are some quadriplegic patient, paraplegic, diplegic patient, and sometimes we exchange our thought and the point of view or mind refreshment, and sometimes we play or sing, and mainly I want to say that we can arrange a group therapy for this type of patient, which will give them more enjoy or refresh, and which help them for, and they we got that the result is very much important for this type of patient.
Thank you, Bristi. Am I pronouncing it right?
Yeah.
Where are you based? Like, where are you working?
I'm from Bangladesh, and I'm working as a physiotherapist in two community-based palliative care project. But what I say that it have done in my hospital base, which I was also a student of CRP Center for the Rehabilitation of the Paralyzed. And we have done this in the CRP, but in the community-based palliative care, we don't have that much resource that we can provide that. But in the hospital setting, I have done this, so I can say it's in the hospital setting or center setting we can do for this.
Thank you, Bristi. Thank you for sharing that. I think 2 years back, till 2 years back, we also had all these group therapies where exactly like you told, they feel first thing is that they feel that it's not just them who are there,
Yeah.
and some people will be very reluctant to go out in a
Go out
wheelchair.
for yeah.
But when they see others also going, we used to take them for outings in a group, 4 or 5 of them. So when they go in a group, then that reluctance is slowly, they'll get over it, and then they become okay in going out, even though the others are staring or
Yeah.
looking at them. So that group, and we used to take them for some gardening works. They can just sit and chat about their lives. And we also it is not just them, as you mentioned, we also will be a part of it, so that it's not just exclusive for them. We all will go there, have a cup of tea with them and come back. That's very wonderful therapy as such. But due to COVID, I think last 2 years we are all struggling with
Yeah.
making sit people together. So it's like a lot of restrictions in terms of rehabilitation, I guess.
Yeah.
Thank you so much. And there is a chart about home care should be encouraged for such a patient with a multidisciplinary team approach. Very, very valid. That is highly recommended. Once we don't tend to keep patients for a long period, right? Sometimes it happens that they think that they come to a hospice or a hospital and then they get cured and then go back. But I think in the people in this group will understand that hospital stays should be very, very limited, and all the interventions or therapies should be taken place in a community, so that there is, because they're going to live for years with this issue. So the sustainability thing, it has to be in a home care setting, or the community should be involved in all this. Thank you so much for the interaction. Anyone else would like to suggest something?
Ma'am, one more thing I would like to add.
Yes, Dr. Vandana.
Ma'am, when we talk about community-based rehabilitation, when we teach the exercises or everything to the caretakers, then psychologically we should deal with the psychological aspects of not only the patient but also the caretakers. And the demystification, that means the transfer of our knowledge to them, should be done. Whether it is a physical, the part of the physiotherapist which they play, the knowledge of that, the knowledge of that aspect, or the psychological aspects. So this needs to be done, and before planning or planning the goal of a person or a patient, we should actually ask what actually they want from us. That means we should involve the patient in goal formation, rather than just we trying to make the goals and then trying to achieve those goals. But we should ask what actually they need and they want from us, why are we going there, and why they came to us. So this needs to be done, because once we try to achieve their goal, what they need, then the purpose of rehabilitation is actually achieved.
Thank you, Dr. Vandana. I think I'm getting wonderful comments, because it's very important to set the goal, as you said. Like, we might be thinking we need to do this, we need to do that, we need to do this therapy, that therapy, but that may not be the thing that patient wants. So it's or they might need more. They might have unrealistic expectations, or they might not want what we are planning to provide. So it's very, very important in any group of patients. The goal setting, very valid point. Goal setting is really important. And it includes bringing them into a realistic goal. Sometimes they may want to walk like normal. So it's very important during the goal setting to have that conversation and set the limits. This is what we can give, and this is what they want. So having that conversation upfront is very, very important. Thank you so much for this wonderful, wonderful feedback. I can read from the Vizag team. Yeah, it's also important to educate and include the caregiver in the goal setting for short and long term. That is again another point, because the patient may want something, but the caregiver's goals might be very, very different. So that is important to have a consensus among the patient and the caregivers. What do they want? What can be achieved? Maybe bringing in a realistic goal and set it. Like, so during admission in our hospital, we have a column to fill goals of admission or goals of treatment, so that it is very clear. Even if the team changes, it is very clear that what was set in the beginning, have we reached there, or have we, I mean, are we not able to reach there? If so, why? So it's very important to document that beforehand, before we offer any of these interventions. Thank you so much for all the valuable interactions. James, would you like to? So I think it's not that very different from what you told. We did exactly, I mean, almost all the same for this particular patient also. Over to you, James.
And as you can see on your screen now, these were the interventions we have made for these patients. For physical pain, we have done pain management, both pharmacological and non-pharmacological, and for the pressure sore, we were able to give nursing care, and we also have given the caregiver education and training, and the physiotherapy intervention to improve his ADL, activities of daily living, and we have also done a occupational therapist consultation, and for socioeconomic pain, we have suggested him to get a vocational rehab, and we have arranged one of our volunteers to give him a spoken English training with the help of a volunteer, and we also started giving him training in computer, and we also started giving him a vocational rehab for the customer service and documentation, and for psychological support. We started. We arranged a psychiatric consultation and management, and regular counseling sessions with the help of social workers. And for the spiritual pain, we made him to finding the meaning in being alive through various rehab support. And these were the interventions we could able to do for this patient.
As I said, it is not that different from what you have all told or suggested. It's exactly the same that we also did, and it still continues. Still, there are ups and downs in terms of psychological and social issues. But again, the team is continuously in touch with the patient, and he comes on and off for admission, so that not particularly for a physical management, but mostly for getting continued counseling sessions, or just be with the team for a few days and then go back home. That's also very important. If your hospice can afford short admissions, that will be a relief for the caregiver as well as for the patient, so that he's just coming back to a familiar place, be there for a few days and then go back. So yeah, so I think that with that we can conclude today's session. I'm so glad about the interactions that we received from this group. It was so wonderful to hear your comments and suggestions. Thank you so much for participating in today's session. And thank you so much, James. And Dr. Rajagopal is not here, but we thank him also for being a part of this today's session. We have more and more interesting sessions coming up, and we expect the same level of interaction in the coming sessions also. Sripriya?
Thank you, Sri. Thank you, Mr. J.